From Microbe TV, this is the Infectious Disease Puscast, Episode 5, recorded on June 22nd, 2022. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. The Infectious Disease Puscast. This is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. I'm Daniel Griffin, and this week Sara Dog is on vacation, so just me. And now on to the literature, shall we? All right, we'll start with our viral section. I always like to remind people, everyone here, that for COVID-related content, please listen to our This Week in Virology TWIV COVID clinical updates. Lots on the episode that will be dropping this week. All right, for starters, an update on the monkeypox. We did hear that the WHO is in the process of procuring thousands of monkeypox tests for Africa. Just remember, you cannot test, treat, and trace until you can test. Dr. Rosamund Lewis, the WHO's technical lead for monkeypox, said during a briefing, there may have been undetected transmission for a while. What we don't know is how long that may have been. We don't know if it's been weeks, months, or possibly a couple years. We already do have a CDC monkeypox tracker. I will put that link in our show notes. But just to give people a real-time update, as I'm recording this, over 3,300 total confirmed cases in 42 countries throughout the world. And this is just like the early days of COVID. You can zoom in on different parts of the world, look at the different numbers in different countries, see who's winning. The UK is currently winning at 793. Germany's coming up close behind at 521, with Spain at 520. Oh no, I was thinking of going to Spain next week. We'll see about that. Okay. But I do want people to feel safe out there. So I'm gonna share some of the current CDC guidance for how you can be safe. The CDC social gatherings, safer sex, and monkeypox. I must admit, with all due respect to the CDC, that I had to inspect the URL to make sure this was really an official CDC thing and not something about, The Onion, making sure it was not April 1st when I read this. There's some stuff in here that if you have some children, put those earmuffs on. This gets a little bit explicit, so to speak. So what are we being recommended to do to stay safe? If you or your partner or think you might have monkeypox, and you decide to have sex, that's what we're being told, consider the following to reduce the chance of spreading the virus. 1, have virtual sex with no in-person contact. Okay, something here about staying 6 feet apart. You can read this for yourself about having sex while remaining 6 feet apart without touching each other, without touching rashes or sores. Consider having sex with your clothes on or covering areas where rash or sores are present, reducing as much skin-to-skin contact as possible. And remember to wash your hands, fetish gear, sex toys, and any fabrics, bedding, towels, clothing after having sex. Now, when I first was made aware of this, I saw an article and it was 2 people wearing parkas and full Arctic gear, and they were rubbing noses, which I'm not sure was safe. I have to be concerned, in all honesty here. I'm going to try not to spend too much. This is not This Week in Virology monkeypox update, but I am concerned we are making the same mistakes. We recently had a Columbia infectious disease morning call discussing monkeypox, and we are running into the same barriers as far as access to testing. I thought we had learned something during the recent ongoing pandemic about how we should not have barriers to testing. If we can't test, we don't know it's out there. So those of you listening, I'm sure how many folks at the CDC and FDA and other places are listening, but we do need to modify our approaches so that we can test, so we can identify who has the monkeypox. And I will share a lot of the recent cases we're seeing, the case we just saw at Columbia, a case that a colleague of mine just saw at Elmhurst. These are really indistinguishable from herpes, from other vesicular rashes. I feel like it's the early days of COVID. The only way that you know it's the monkeypox is to do a test. All right, moving on. In JAMA Network Open, effect of point-of-care testing for respiratory pathogens on antibiotic use in children, a randomized clinical trial. So we were all excited. We're going to have all these tests. We're going to look for respiratory pathogens. Hopefully, this is going to allow people to use less antibiotics. Unfortunately, the authors found that multiplex PCR point-of-care testing for respiratory pathogens did not reduce the overall antibiotics given in the emergency department. 27% in the intervention group, 28.5% in control. No significant change. All right. Letter published in ICU Medicine, outbreak of hepatitis in children, clinical course of children with acute liver failure admitted to the ICU. This was a summary of the ICU course of 8 patients. And lots in the recent JID about respiratory syncytial virus vaccine. So let's talk about this. The article, 3 dose levels of a maternal respiratory syncytial virus vaccine candidate are well tolerated and immunogenic in a randomized trial in non-pregnant women. What will our pediatric colleagues do if they're not staying up all night admitting children with RSV? Perhaps sit on vaccine committees. These are the results of a first in-human placebo-controlled trial. 502 healthy non-pregnant women were randomized 1:1:1:1 to receive a single dose of unadjuvanted vaccine containing, and what are these different groups? 30, 60, 120 micrograms or placebo of the RSV fusion protein stabilized in the prefusion conformation or placebo. So basically a bunch of different doses of the vaccine or placebo, and they found that the higher the dose, the better response. Also well tolerated with no vaccine-related adverse reactions. They plan to move forward with the highest doses. But just a little background around RSV, respiratory syncytial virus. Why are we so excited about vaccines for this arena? RSV is the most common cause of lower respiratory tract infections in children less than 1 year of age here in the United States. Prior to the COVID-19 pandemic, the global annual rate of RSV hospitalization among children less than 5 was about 4 to 5 per 1,000 children. This is really high, and the RSV hospitalization rates were highest among those children in the first 6 months of life. So let's think about that. If we can get women vaccinated, if we can give women access to vaccination during pregnancy, if they can then transfer that passive immunity to their children, we're really going to be able to do something, hopefully, during those first 6 months of age. But I do want to point out RSV is not just an issue in children. I think a lot of clinicians make that mistake. In senior adults that get hospitalized with RSV, the mortality is twice that of those hospitalized with influenza. All right, moving on to the bacteria. The article, Leptospirosis in Retirees Living in Rural Areas, a poorly recognized emerging problem in mainland France, was published in Open Forum Infectious Disease. Now, among 40 patients diagnosed with leptospirosis in 3 hospitals of Western mainland France between 2014 and 2018, half were at least 60 years old and retired. Their exposure factors were mainly rural residential environments with limited remarkable risk factors. Other than that, they go on to say better awareness and information on leptospirosis appeared necessary in this population. Yes, I think the question mark at the end of that title is certainly warranted. Perhaps it should have had the classic ending that we remember from the days of Mark Crislip. Leptospirosis should be included in the differential diagnosis of all elderly French people who get sick, particularly if they come from a rural area. All right. Now, I felt like there was a pit in my stomach when I read this article. A prospective randomized study comparing ceftolozane tazobactam to standard of care in the management of neutropenia and fever in patients with hematological malignancies. In this prospective randomized trial, the investigators compared using ceftolozane tazobactam, a new cephalosporin beta-lactamase inhibitor, to the standard of care for the empiric treatment of neutropenia and fever in 100 patients with hematological malignancies. So cefepime, piperacillin tazobactam, better known as Zosyn, or meropenem, were the standard of care. Those folks that got the cephalosporin beta-lactamase inhibitor combo, the ceftolozane tazobactam, had a higher rate of favorable clinical response, 87% versus 72. Superiority tests showed that the new combination therapy led to significantly lower rates of clinical failure at test of cure, 6% versus 30%, and late follow-up. I am worrying more and more about the growing amount of microbial resistance out there, antimicrobial resistance, AMR. All right, are we preaching to the choir with this next article? The article, Development of an Electronic Algorithm to Target Outpatient Antimicrobial Stewardship Efforts for Acute Bronchitis and Pharyngitis, was published in Open Forum Infectious Disease. Several of us have this optimism. Yes, you heard that right. Optimism that the electronic systems clinicians are using can be allow us to direct them at the point of care to use the appropriate antibiotics when warranted, and not use antibiotics when, say, the patient has a viral infection or an asymptomatic UTI, viral pharyngitis, for instance. So here, the investigators were evaluating an electronic algorithm and tell us that of 300 subjects with bronchitis, 55.7% received an antibiotic inappropriately based on chart review. The electronic algorithm demonstrated 100% sensitivity and 95% specificity for detection of an inappropriate antimicrobial prescribing. Of 300 subjects with pharyngitis, 31% had an incorrect prescribing decision. Among 29 patients with a positive rapid strep test, that should be a no-brainer, 93% received an appropriate antibiotic, and 100% received the correct duration. So the electronic algorithm in this study demonstrated very high sensitivity and specificity for outcomes. We are all hoping that this will really spread, will allow us to, at a point of care, have that support that everyone needs to do the right thing by our patients. So optimism here. Now, I love this one. This is back to the days of Aerosmith, which we seem to be returning to. The article, Phage Therapy of Mycobacterium Infections, Compassionate Use of Phages in 20 Patients with Drug-Resistant Mycobacterial Disease, was published in Clinical Infectious Disease. Mycobacterium isolates from 200 culture-positive patients with symptomatic disease were screened for phage susceptibilities. One or more lytic phages were identified for 55 isolates. Phages were administered intravenously by aerosolization or both to 20 patients, so intravenous or through the air, to 20 patients on a compassionate use basis, and patients were monitored for adverse reactions, clinical and microbiological responses, the emergence of phage resistance, and phage neutralization in serum, sputum, or bronchoalveolar lavage fluid. Favorable clinical or microbiological responses were observed in, I'm going to say, only 11 patients. So interesting. But as we have discussed, and we will continue to discuss, some of the challenges with phage therapy is it's sort of a one and done before the immune system recognizes that phage, and we have to move on. All right. The article, Microbial Cell-Free DNA, identifies the causative pathogen in infective endocarditis and remains detectable longer than conventional blood cultures in patients with prior antibiotic therapy, published in Clinical Infectious Disease. Now, right now, when we're worried about endocarditis, we're doing blood cultures, we're waiting to see what grows. Sometimes we still have this concept of culture negative endocarditis. So this study was evaluating the potential utility of microbial cell-free DNA as a tool to identify the microbial etiology of infective endocarditis. So basically doing a DNA test on the blood to figure out what might be causing that infective endocarditis. So this tool was used. 23 patients with definitive infective endocarditis were included for analysis. Both this DNA technology and blood cultures had a sensitivity of 87%. As we hear from the title, though, this may be a tool that we can use in individuals that got prior antibiotics. All right. Now, this one I really like. Not that I don't like the others also. The article, The Source of the Black Death in 14th Century Central Eurasia, was published in Nature. I think this was a listener pick on one of the other Microbe.tv podcasts, but let me start with a little background here. So the Black Death, or plague, is caused by the bacterium Yersinia pestis. There were several waves or pandemics due to the plague, so this will not be our last word on this topic. The first plague pandemic was the plague of Justinian, or what people refer to as the 6th century outbreak. But this article focuses on the sources of the better-known second pandemic, or the Black Death pandemic of the Middle Ages, where some suggest a third to two-thirds of Western Eurasia died due to this pathogen. The story is that this infection first impacted the Mongols, who were attacking the Italian trading station Krapha in the Crimea, and that the Mongols then catapulted plague-infected corpses into the city. When the Italians fled in ships, they were believed to have brought the disease to Europe. There was then a third plague, which we're not going to talk much about, right around 1900 that spread to San Francisco, and it was responsible. It was during that time that actually Alexandra Yersin isolated the bacterium responsible, and the whole rat flea connection was better understood. But what I will say in this paper, these researchers did DNA analysis of tooth powder. They actually looked at teeth that were excavated from cemeteries located near a lake in modern-day Kyrgyzstan and sequenced short fragments of DNA. The data they generated supported this area as a source of the 14th century or the medieval Black Death pandemic. We still see hundreds of cases of plague each year, with about a dozen each year out west due to the prairie dogs and fleas. All right, fungal, and we've got some stuff this time, a little push to those folks publishing in the fungal arena. The article, Non-Invasive Testing and Surrogate Markers in Invasive Fungal Diseases, was just published in June 2022 in Open Forum Infectious Disease. Now, I'm going to encourage people, go back, go to our webpage, go to this article. They have a great table that really pulls things together, has a nice list of the different fungi, the diagnostic biomarkers, prognostic biomarkers, surrogate endpoints for treatment trials, looking at Cryptococcus, Candida, Aspergillus, other molds, Blastomyces, Cocci, Histo, Paracocci, Sporothrix, Tauromyces. So really, really helpful stuff, looking at different approaches, PCR, antigens, galactomannan, fungitel. So I will encourage everyone to go ahead and use what really is, I think, a helpful resource for sorting out some of these tests. All right. The article, Controversies in the Management of Central Nervous System Coccidiomycosis, was published in Clinical Infectious Disease. Now, I was all excited. Controversies. I figured this would create this big social media controversy with the high-dose fluconazole folks on one side and those noting the absence of studies demonstrating better outcomes with higher doses, shouting, name-calling, things like they were practicing witchcraft, the need to do proper trials, showing photos of bald folks with, alopecia that was induced by high-dose fluconazole. But unfortunately, this was really more of a consensus than much controversies. I will keep scanning social media for the Twitter battles, but this is a nice resource for what we do and do not know, and what future research we should be doing with regard to the management of CNS coccidiomycosis. All right, some parasitic stuff. And here I will say, be sure to listen to This Week in Parasitism, where we give you the challenge of trying to solve a mystery case each month. Should really be this month in parasitism. But let us start with the WHO published their new WHO guideline for the treatment of visceral leishmaniasis in HIV co-infected patients in East Africa and Southeast Asia. In East Africa and Southeast Asia, liposomal amphotericin and miltefosine over just liposomal amphotericin monotherapy for individuals with visceral leishmaniasis HIV co-infection. In East Africa, conditional recommendation, very low certainty evidence. They go on to say, in Ethiopia, the new treatment strategy was shown to have an 88% efficacy rate at the end of therapy after 58 days, whereas the efficacy of current standard treatment was 55%. So we're getting up to 88 from 55. In India, the new treatment regimen was efficacious for 96% of cases after 210 days, while a lower rate of 88% was observed for cases receiving standard treatment. So you can see sort of a consensus recommendation for using a combination of liposomal amphotericin and miltefosine. I'm going to give credit for Doctors Without Borders for helping pioneer this approach. But we certainly are seeing the biggest impact here in East Africa, right? Going from 55 up to 88. We're already doing fairly well in other areas of the world. So, all right. Broad antimicrobial resistance in a case of relapsing babesiosis successfully treated with tafenoquine was published in Clinical Infectious Disease. Babesia becoming antimicrobial resistant. Now, here the authors describe a case of relapsing babesiosis in an immunocompromised patient. For our listeners who are not familiar, this is that parasitic disease that every new fellow presents as a mystery case, and they're not familiar with how common it is here in our area. So we usually get it right away, and then they're sort of deflated. So, if you're one of those seasoned attendings and a new fellow is presenting a mystery case of Babesia, please act excited when it is unveiled. But what are we to do if we start getting resistance? Now, a point mutation in the Babesia microti 23S RNA gene predicted resistance to azithromycin and clindamycin, where an amino acid change in the parasite cytochrome B predicted resistance to atovaquone. Following initiation of tafenoquine, symptoms and parasitemia resolved. All right. Now, this one reminds me of Dixon des Pommiers and the Japanese dropping pamphlets on the U.S. troops. This article is about that disease, which my son fears most of all maladies on the planet. The article, Human Filariasis in Travelers and Migrants, a retrospective 25-year analysis at the Institute of Tropical Medicine, Antwerp, Belgium. This was published in Clinical Infectious Disease. Now, this was a review of all cases of filariasis diagnosed at the Institute of Tropical Medicine, Antwerp, Belgium, from 1994 to 2018. As I mentioned, this reminds me of this story that Dixon des Pommiers loves to tell about how the Japanese would drop pamphlets on the U.S. troops in the Pacific theater, warning them that they would get this horrible disease and it would do terrible things to their private parts. Well, in this paper, a total of 320 patients, median age 41, 71% males, were diagnosed with 327 filarial infections. They had Wuchereria bancrofti, Onchocerca volvulus, Loa loa, Mancinella perstans, some unspecified species. They go on to tell us that European long-term travelers accounted for 52% of these cases. Visitors, migrants from tropical countries for 34%. They say Central Africa was the likely region of acquisition for 92% of those patients. All right. Now, this next one, I have to say, is a little bit disturbing. The article, Intravenous, well, not as disturbing as the monkeypox advice, but disturbing in a different way. The intravenous vitamin C in adults with sepsis in the intensive care unit was published in the New England Journal of Medicine. Now, this is a situation where negative data is really critical. Now, to this day, many people in critical care medicine continue to give high-dose vitamin C as part of a cocktail that did not withstand the test of a proper trial. When I speak to these physicians, the initial response was, well, at least it does not do any harm. Not sure about that after this trial. So these are the results of a randomized placebo-controlled trial looking at adults who had been in the ICU for no longer than 24 hours, who had proven or suspected infection as the main diagnosis, and who are receiving a vasopressor to receive an infusion of either vitamin C at a dose of 50 milligrams per kilogram of body weight, or matched placebo administered every 6 hours for up to 96 hours. So this is ICU level sepsis. The primary outcome was a composite of death or persistent organ dysfunction, defined by the use of vasopressors, invasive mechanical ventilation, or new renal replacement therapy on day 28. A total of 872 patients underwent randomization, 432 to the vitamin C group, 437 to the control group. At 28 days, death had occurred in 35.4% of the patients in the vitamin C group and 31.6% in the placebo group. So a relative risk of 1.17. So increasing your risk. And persistent organ dysfunction, 9% in the 9.1% in the vitamin C group, 6.9% in the control group. So here, a relative risk of 1.3. In the vitamin C group, one patient had a severe hypoglycemic episode. Another had a serious anaphylaxis episode. So to sum this all up, in adults with sepsis receiving vasopressor therapy in the ICU, those who received intravenous vitamin C had a higher risk of death or persistent organ dysfunction at 28 days than those who received placebo. So not helpful, and looking like there may be harm. All right, more on the ICU in critical care medicine. Therapeutic hyperthermia is associated with improved survival in afebrile critically ill patients with sepsis, a pilot randomized trial. This was testing the hypothesis that external warming using forced air warming blanket for 48 hours of critically ill afebrile septic patients would improve immune function compared to standard temperature management. There was no difference in monocyte HLA-DR expression or interferon gamma production, but 28-day mortality was lower in the intervention group. All right. I like this next one. The article, Does a School-Based Intervention to Engage Parents Change Opportunity for Hand Washing with Soap at Home? Practical experience from the Makoni Safi trial in Northwest Tanzania was published in PLOS Neglected Tropical Diseases. So the authors reported that engagement of parents and guardians in a school-based WASH, W-A-S-H, education intervention resulted in increased knowledge and motivation about hand washing and sanitation. This led to improvements in sanitation facilities and hand washing opportunities at home. However, long-term success in provision of water and soap was limited, indicating that sustained engagement may be required for the encouragement of households to ensure these materials are consistently available at home. Now, this may seem odd. We talk about the American Society of Tropical Medicine and Hygiene, but some of these communities that I first go to with different groups, I'll use Floating Doctors in Panama as an example, soap and hand washing is something we introduce, not something that a lot of communities are doing across the world. Remember, this requires the purchase of soap, somehow getting this magical substance, and then actually use of water. And in many areas, water is a very limited resource. So really, I think, eye-opening. All right. Well, I will finish with the article, Infectious Diseases Compensation in the USA, the relative value, published in The Lancet. Well, as my dad always says, if you find a job you love, you will never work another day in your life. Since many of our listeners are infectious disease specialists, they're likely aware as this article tells us, that infectious disease salaries rank among the 5 lowest paid specialties in healthcare. Now, once you move past the title and how little we get paid, they then talk about how cool we are. So this is what I want you to focus on. I'm thinking these are the great one-liners that we can all use at those next big indoor poorly ventilated event you attend with your masks off. The authors suggest that following numerous worldwide health threats, including SARS-CoV-2, HIV, Zika virus, Ebola virus, multi-drug resistant bacteria, and now monkeypox, the need for infectious disease physicians has never been more evident. That seems like a long one for a one-liner. Okay, the next one. Infectious disease consultation has been shown to reduce in-hospital mortality by 19% and cost of stay by 41%. Additionally, infectious disease physicians are instrumental in making crucial infectious disease diagnoses, such as epidural abscesses, where diagnostic delays lead to poor patient outcomes, some of which are borne out in malpractice lawsuits. If awarded, the average malpractice ruling stands at $5 million for each epidural abscess. Preventing a single lawsuit would pay the yearly salary of 25 infectious disease specialists, well, at least. This reference they cite is an example of, they also cite the reference of, as they're paying the ID docs less and less, the salaries of hospital executives have doubled. So, all right. Well, hopefully we have encouraged folks to go into infectious disease. Hopefully now they have some great one-liners about why they don't need the money because they are just so valuable. And that brings us to the end of this podcast. As always, references for this show are available at Microbe.tv, the home of our multimedia empire. You can find the Infectious Disease Puscast at Apple Podcasts, Microbe.tv/Puscast. We love to get your questions, comments, and paper suggestions. Send them to Puscast@Microbe.tv. Consider supporting the science shows of Microbe TV at Microbe.tv/contribute. You can find Sara Dong at Twitter at SWINNDONG, at Febrile Podcast, or at febrilepodcast.com. She wasn't here, but she did help contribute some articles for this week. And I'm Daniel Griffin, and you can find me at parasiteswithoutborders.com, on Twitter at Daniel Griffin MD, as well as on the other podcasts, This Week in Parasitism and This Week in Virology COVID Clinical Updates. Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.